Hello guys, and welcome back to my channel here at Pathopharm 101. Today we're going to be talking about wounds, which is a very serious topic. Or is it sanguineous? I can't remember. Let's talk about it. So first we have our serous drainage, which is going to be this top picture right here, our clear fluid, which is primarily water. And then we have our sanguineous fluid, which is bright red, which means active bleeding in our wound, which is not good. Then we have serosanguineous, which is just what it sounds like, serous and sanguineous. So it has our clear fluid in it, but it might have a little excess bleeding, so it makes it this pink color. Then we have our purulent drainage right here, which is going to be a pus, a yellow, green, tan, kind of mucousy consistency. It's usually a buildup of our white blood cells and different microorganisms that have gotten into the wound, usually meaning there's an infection, which is not good in any wounds, which we'll get into here in a little bit. So what can we use to catch all of this drainage that's coming out of the wound? We have different drainage devices. So first we have our JP drain, which is our Jackson-Pratt drain. You can see it up in this right-hand corner. It's like a little bulb that drains our fluids based off of suctioning. So what you'll do is you'll squeeze the bulb before attaching the tubing so that it provides a suction to create a nice flow of drainage to that. Then we have our Penrose drain over here, which is just tubing that sticks out of the wound to allow natural flow of any excess fluid, so to prevent accumulation of fluid. There's no pump, there's no suction, it's just a natural flow of excess fluid coming out of that. Next, we have our Hemovac drain right here, very similar to our Jackson-Pratt drain. It's built off of suction. You'll just squeeze it the same way as you would a Jackson-Pratt. It's just a little bit bigger to catch any draining there. Then we have our negative pressure wound therapy. This is for our bigger, severe wounds that are exposed to the external environment. So it consists of a vacuum pump, a drainage tube. It also acts as a wound dressing and then covered with an adhesive film. So basically what this does is it's going to actively pump out any fluids or drainage from the wound site and pull the wound edges together to approximate those edges to promote better healing. So here you can see it was open, now you're suctioning, and then eventually it's gonna close nicely with those edges approximated. Okay, so what are some things to consider whenever we have an open wound for our patient? So we want to make sure to record the drainage amount. So whenever we're measuring from those drainage devices, we're going to have to empty them. Whenever we do, we need to be paying attention to the amount of drainage there is, the consistency, the color, and if there's an odor. We also need to check the function of our drainage devices to make sure that that suctioning is still actively suctioning, because you don't want to have press down a Hemovac and then it just expand without having any drainage in it. We also want to be considerate that our darker skinned patients will have color variations in these different drainage types. So the different types of wounds are acute and chronic wounds. So our acute wounds are going to be as a result from surgery or trauma. So the very what you would think of as a wound that's short term. So it becomes chronic whenever the healing process is prolonged to usually more than it should, maybe weeks, months, longer than it should, because it's not following the correct stages of our healing process that we're going to talk about. So what do we see whenever we're talking about wound healing? So first it's going to start off with hemostasis, our blood clots, to prevent any further active bleeding. Then there's inflammation, where our neutrophils are going to swarm the area and create a swelling or redness to prevent any infection, kill off any bacteria that may be in the wound. Then there's proliferation, where the cells are going to try to regenerate to fill in that gap where the wound may be susceptible to infection. Then there's remodeling, where the tissues have repaired and they're filling in those gaps. So our healing process, we have three different intentions of our healing process. First is primary intention, where the edges are approximated. This is usually from a simple cut, right, where the wound isn't creating the edges to separate, that they're still together, but they're still a wound. So a surgical incision or a paper cut. Next is secondary intention, where the edges are not approximated, to where it may be an ulcer where it's open, or it could be from a trauma or an infection where the wound may have started out small, but then it's expanded. Then we have tertiary intention, where there's delayed closure from that infection that's created a larger wound and possible necrosis. The healing process can be improved upon by maybe suturing of granulation tissue to promote that healing process. So this is basically just a picture of the primary and secondary intention. As you can see in primary intention, the edges are closely approximated, so it may heal quite a bit faster with little to no scarring or tissue damage. While here on secondary intention, it's a much larger wound that may take a bit longer and leave maybe an indent, so you can kind of tell that there was a wound there versus our primary intention. Okay, so moving on to pressure ulcers. Pressure ulcers are a very important type of wound that recur very commonly in our hospitals from our immobile patients. So a pressure ulcer is a localized injury to the skin or underlying tissue, typically over a bony prominence. Because if you think about it, there's not a lot of cushion in between a bone, right, and then whatever surface you're sitting on. So it can cause more irritation to that skin. So what are our risk factors? Immobility, inadequate nutrition, incontinence, decreased sensation where you can't feel that there's any pressure there, advanced age, casts and restraints, and obesity. So how would we assess this, right? We have our ADPI. First is assessment. We assess pressure ulcers with our Braden scale. So we'll typically sit here and look at this and say, oh, sensory perception. Is our patient able to feel the pressure? Is the moisture, are they occasionally moist? Are they very moist, or are they consistently moist from their incontinence? There's activity tolerance, mobility, nutrition, friction, and shear. And all of these things you'll score from a 1 to 4, and then depending on that scale determines the risk that your patient is at for a pressure ulcer. So what are our different stages of wounds? So first we have stage 1, which is non-blanchable. So it's this kind of redness that occurs from extended sitting or extended pressure on this particular area of your patient, but it is no longer blanchable. Whenever you press on it, it doesn't have that white that returns. It's just red. So and then we have our stage 2 ulcer, which is our partial thickness skin loss. So it's cut through the skin now, and you can see into the dermis, but it hasn't really cut through that tissue yet. It's just the skin that's gone. So then we're moving on to stage 3, which is a full thickness injury. So it is now cut through the epidermis and partial of the dermis. So now you can see the underlying tissues there. And stage 4 goes even further than that it's not only gone through the epidermis and the dermis and part of the tissue. Now you can see fascia, muscle, tendons, ligaments, cartilage, bones. So that must be really bad, and that makes a patient more prone to infection. So now second is diagnosis. So we have assessment and diagnosis. What are some possible diagnoses we can put for patients who have possible pressure ulcers? So we have impaired skin integrity related to mechanical factors and physical immobilization. We have impaired skin integrity related to impaired circulation and imbalanced nutritional state. We also have acute pain related to impaired skin and tissue integrity. So what's next? Planning. So what's our plan for this patient who has a pressure ulcer, or a risk for a pressure ulcer? We want to make sure if they have one that we're cleaning that wound to promote healing and potential closure of that wound so that it eliminates any problems for infection. So our goals are to have no deterioration. We don't want to have it worse. We want to reduce or eliminate the factors that lead to these pressure ulcers. We want to not develop an infection, and we don't want to have any reoccurrence. We want to make sure that it's healing properly. So what are some interventions we can apply to this, right? So we can identify the patients that are at risk. We can implement prevention strategies, such as here's a waffle bed, or a low airflow mattress, or a wedge pillow, or foam boots to prevent that pressure on these bony prominences of the body. So then we can also reposition our patient every 2 hours so that they're not constantly sitting on one side or the other, or on their heels or on their sacrum. We want to make sure that there's pressure relief. We want to make sure that the skin is clear and dry. If they have incontinence, that we're checking up on them to make sure that we're changing those pads so they're not constantly sitting in their urine. We want to make sure that the patient has adequate nutrition and hydration to promote healing to those wounds. Use lift sheets whenever removing the patient to prevent friction and shear. Cleanse the wound to make sure there's no infection possible, and debride the wound if the healthcare provider orders it. Last but not least, we need to make sure to follow up and evaluate these interventions. Have our interventions work? Have they done what we wanted them to do? And here are our sources that we got these from. Now, I wish you best of luck on the final, and I hope this video helped you to better understand wounds and wound care and wound healing. Now you should be an expert on wounds, right? Good luck on your final, and thanks for watching.